Tara is a family doctor, and she's part of an unbelievable acronym, SMHAFHT, St. Michael's Hospital. Many of you know St. Michael's Hospital in Toronto. It's one of this country's top tertiary centers. Those orange helicopters, they land on its roof. That's where they do some very, very high-end procedures. But they also have a family health team which serves the downtown southeast of the city, which does include some of our more disadvantaged postal codes. The letter A is in there as academic because she is also part of the University of Toronto, where she is the vice chair in quality and innovation at the Department of Family and Community Medicine and holds the Fidani Chair in improvement and innovation. So she's someone who practices, but is also quite relentless about trying to improve the system and does so from a very interesting vantage point at St. Mike's. Tara's going to talk for about 20 and 25 minutes, and we'll have about 15 or 20 minutes for questions. And she's going to try and lay out how primary care can be delivered and how Ontario stacks up against some different jurisdictions. So she's going to share her screen now because she wants to drive the slides. So they'll pop up. And Tara, I'll hand things over to you.
Thank you, Peter. And thanks everyone for providing the generosity of your time in these discussions. I loved hearing about the values you've been discussing and looking forward to where you land with those. As Peter says, I'm going to take the next 20-25 minutes to talk really about our Ontario primary care system and contrast it and the way it works to some other international primary care systems. And I'm going to do that in a couple of different ways. I'm going to present with you some data from two surveys done by the Commonwealth Fund that compares Canada to 10 other Commonwealth countries. One of the surveys is of primary care physicians, and another survey that was in 2019, and another survey 2020 of the general population. And then I'm also going to share with you some work that I did together with colleagues Rick Glazer and a medical student, Hiba Shahid. And we did this work over the summer to really try and identify some other countries where they have a higher portion of people who have a family doctor or NP or place of care for primary care. And we wanted to set out to see what could we learn from those countries, keeping in mind that we know that we have sometimes different geographies, different cultural contexts, the actual platform of the healthcare system and how it's funded is different. So there's lots of differences between these countries. So we can't just, cut one thing and paste it onto ours. However, I do think that there's a lot we can learn. So I'm going to start by just sharing with you this slide that compares Canada to several other countries we have identified, 9 other countries from the OECD that have, these 9 countries have higher rates of what I call primary care attachment. And when I say primary care attachment, I mean people in the population having a family doctor, nurse practitioner, or other primary care clinician, or regular place of care. And so you can see here in Canada, so the blue here is having a regular doctor, GP, nurse practitioner, etc. And the orange is actually having a regular place of care. And what you can see here is Canada faring, about 80, a little under 85% having a regular doctor, with another, 7% or so having a regular place of care. But then you can see these other countries, in countries like Norway or the Netherlands, Finland, where they have actually close to 100% of their population having a family doctor or a regular place of care. So when we looked at some of the different, we looked at a number of different metrics to start with to compare these 9 countries with Canada. And one of the one of the ones that I want to highlight a couple to you, starting with this one, which is the number of general practitioners, or here I'm using the term GPs family doctors, general practitioners interchangeably, so forgive me, but here it's the number of general practitioners or family doctors per 10,000 people. So, and what you can see is that Canada has kind of about, the average amount of GPs compared to some of the others. So the number of general practitioners per 10,000 is on the x-axis, and Canada is kind of there in the middle. And why it's below is the y-axis is the percent of people with a regular primary care provider or place. So of course, Canada is lower than these other countries, but when it comes to the number of family doctors or equivalent, it seems like we're actually pretty similar. But then when we looked more broadly at the total number of physicians, so this is not just family doctors, but total physicians, what we can see here is that Canada actually, so again, the x-axis is the number of total physicians per 10,000, and you can see that Canada is number of physicians is actually much lower than some of these other countries. And there does seem to be some kind of a gradient here with the percent of people, where countries with it seems to have a higher proportion of or higher per capita number of total physicians having higher proportion of people with a regular primary care provider or place. But when we also did some interviews with stakeholders in some of the countries to better understand the details. And what was interesting is that we came away with the realization that sometimes these numbers are in fact misleading, especially in Canada. Because when we look at the GPs, just the head count of GPs, it's not telling us the same thing across. Especially in Canada, not all family doctors are practicing comprehensive longitudinal office-based care. So in fact, in most of these other countries, when they're counting GPs or family doctors, they are counting people who are doing regular family practice where they're seeing people from birth to death and taking care of all of their needs. However, when we count it, we're actually including about people who do a number of specialized work, and the number of family doctors doing specialized work has really increased over the last while. So now about 30% of family doctors in Canada practice in specialized areas. So they do emergency medicine. So many of our emerged departments across the country are staffed by family doctors, but they also work in the hospitals. They might do palliative care, sports medicine. And as you can imagine, I think the value of what these different kind of areas are that family doctors are working in probably also differs across the country, and we can talk about that. And then in addition to the 30% doing these specialized areas, there's also some who work in walk-in clinics. And so they're not doing that, seeing everybody and seeing them over time and looking after all of their needs on an ongoing basis. So when we look at just the number of GPs, it's not telling the whole story. Having said that, it's pretty clear that Canada actually does seem to have fewer doctors overall than these other countries. And we do need more doctors. I think that is actually, borne out by a lot of the demographic data that's coming out. So we have an aging population, lots of immigration. At the same time, medical school enrollment was actually decreased by 10% during the 1990s. And what that's meant is that we have actually this kind of divot in our doctor population, because during that time we weren't training as many doctors as we probably should have. And so what that means now is we actually have more doctors who are 65 and plus. So all this to say is we do need more doctors. But the more we looked at this data together as a team, it also became clear to us that having more doctors alone is not going to get us where we want to be, especially given some of the demographic trends that we were talking about. And so when we looked at all these other countries, there were other things about them and the ways that their primary care system worked that we felt could offer some really important lessons for Canada. So these relate to everything from funding to the way the overall system is actually organized, but also just accountability and the way that the family doctors and general practices are set up, how they're paid, how they work together, and importantly, the information systems that these countries have that support, the support healthcare and primary care. So I'm going to go into these in a little bit more detail now. And but I do also want to say that one of the other important things that we recognized as we were doing this work as well is that Canada actually spends less on primary care as a percentage of the total health budget than many of these other countries. So you can see Canada here on the left. What I have on the y-axis is the percent of all total health spending that's on primary care. I have removed dental care from this graph, so dental care isn't represented here. And if you take, and I've gotten this data from the WHO and the OECD, and what you can see here is that Canada spends about 5.3% of their total health budget on primary care, whereas these other countries, all told, have an average of about 8.1%, so much less. And so this translates to millions, probably billions of dollars that we need more of to really invest in our system. Another thing that I actually don't have a slide on, but that I also realized I wanted to share with you is that when we looked across all of these countries, the other thing from the system and funding perspective that stood out is that when we looked at how healthcare was funded, public and private, actually all the countries that we talked about, those 9 comparator countries, they all have actually a higher portion of total health spending that is public versus private compared to Canada. So I'm now going to go into some more detail about some of these lessons that I think we can learn and contrasting kind of Canada to some of these other countries. So first of all, how is it that people go about finding a family doctor or nurse practitioner? So in Ontario, people are often left to find their own family doctor. There's a website put out by our College of Physicians and Surgeons of Ontario that tells patients which doctors are accepting patients, but in reality, very few are. And then there is a service in Ontario where called Healthcare Connect, where people can register and they're technically supposed to help them find them another family doctor or NP. But actually, unfortunately, in reality, that system doesn't work very well. I have patients who've moved away to a city in Northern Ontario, for example, and have been told it's a 10-year wait list on Healthcare Connect realistically to get another doctor. So that's a system that's not working well. So contrast that with these other countries, these other 9, and I'm specifically going to probably talk a lot about Finland, Norway, the Netherlands, and the UK. These are 4 countries where we've had an opportunity to talk to some primary care experts and learn about them. So in some of these other countries, for example, in Finland, patients are actually automatically registered to their local health center. And in Norway, actually, they're automatically registered to a local GP practice. In the UK, they don't have automatic registration, but what they have is that the local clinic pretty much has to accept you. So if you move to the UK, you'll get a choice of, let's say, 3-4 clinics that are in the nearby area, and I should say practices. And you don't know which physician you would be able to get within that practice, but you're connected to the practice and that practice has to accept you. In the Netherlands, it works a little differently. So you have a choice of a local GP, and that's kind of advertised on the websites, and you're really encouraged by, they have, by the insurance providers in the Netherlands, they're really encouraged to find, you're really encouraged to find a GP. And if all of the GPs in your area are full, the insurer is really, their responsibility to help you to find one. I will say that in, for example, countries like Norway, where you are automatically registered, it seems that you do have a choice to change, I think, up to once per year, the GP. So even though you're automatically registered to one, you actually can change as well. So what is a little bit different in some of these other countries too, though, is like what these processes means in terms of having a relationship with one family doctor or NP. And I loved how one of you, I think, brought out this concept of the tension between timeliness and continuity. And I think there's also even like a tension here between, attachment to a primary care practice versus like an individual physician or NP who could provide continuity from a person perspective. So in Ontario, actually, one of the areas where we do really well is that we have high levels of continuity, and we have, people generally have an ongoing relationship with a family doctor or NP. And that's the case in some of these other comparator countries too, like Netherlands or Norway. But then in Finland and the UK, for example, often patients are more attached to the practice, and then the practice, because of some other requirements, especially around ensuring timely access, the patients often see different doctors within that practice. So there's lower levels of continuity, but they do have a practice, the same practice that has their records where they are seen on an ongoing basis. Certainly in these other countries, they encourage care that's close to home, and they've kind of set up their systems so that primary care really ideally should be delivered close to home. And that's how, for example, you're automatically registered in some of these countries. But in Canada, of course, I think you can theoretically choose any family doctor or nurse practitioner you want, but in reality, that's because it's so hard to find. Sometimes people do travel long distances, and people may move and actually stay with their family doctor because they like them and they feel they have that ongoing relationship. So the other way in which there is, some differences, and this one is a little bit harder to parse out, is related to teams. So all countries are trying to move towards having more use of other health professionals alongside family doctors. So in Ontario, I'd say about 25 to 30% of people have a family doctor who is part of who's working in a team-based model. So usually that's a community health center or family health team. So as Peter mentioned, I work at the family health team at St. Michael's Hospital. I'm lucky to work together with nurses, nurse practitioners, social workers, pharmacists, a dietitian. We even have an income security health promoter. We have a chiropodist. We actually have 2 physiotherapists, and that's to support. We look after 50,000 patients or so at 5 clinic locations. So there's a wonderful team, and that team is shared among all of the physicians and patients of the center. But at the same time, I would say that, so this has really made my life, I would say, as a doctor, much more enjoyable. I feel I can provide better care. We've actually done a lot of research that has shown that, the team-based care actually can improve quality when it comes to chronic condition management. It can reduce emergency. It seems to be related to lower emergency department use. But the ways in which we've implemented teams in Ontario actually hasn't led to what I would say is increased capacity. So one of the things we so often in family practices with teams, we're asking our nurses to do some tasks, for example, or we're asking our pharmacists for a consult, but it's usually in addition to what we're doing as a doctor. It's not usually in substitution. So it's not taking work away always from the doctor. The doctor is still often doing the same work, and then patients are getting added benefit from these other health professionals. And more, as we've been doing some thinking about this, when we look to the US and many of these other countries and the thought leaders there, we can see that there's an opportunity for teams actually to increase the capacity of family doctors and nurse practitioners to actually see more patients, because they are able to do some of the tasks that the family doctor would normally be doing. So one example of that would be, for example, well baby care, immunizations. In countries like the UK, those tasks are really done mostly by nurses. Interestingly, in Finland, the first point of contact at these healthcare centers are nurses. So the nurses speak to the patients and then decide, what's the next course. Do they need to see a family doctor, or can they be perhaps the nurse themselves can manage it, or perhaps it's another member of the team. And so in other health professionals, other than nurses, are also increasingly parts of some of teams in some of these other countries. So interestingly, in Finland, they have often physiotherapists and psychologists in particular. So one other piece that I wanted to highlight today was around urgent care and after hours. I heard the importance of timeliness when you were talking about your values. And the values that are important. And of course, it's really important when you have an urgent issue that you're able to be seen. So interestingly, in Ontario, I would say the majority of practices, because of the contract that we have as a patient enrollment model type of practice, we have accountability to provide some after hours care. But what's interesting is that it really varies in terms of just how it's advertised. Sometimes the patients don't actually even know about it, and how it's run. So sometimes, even though you're theoretically so basically the accountability is for a big group. So let's say you might have the groups can actually range in size from 3 doctors to, 200 doctors. And really the accountability lies for coverage for that group. And so you can imagine that some groups might organize things differently. At our own team at St. Michael's Hospital, we have, organized after hours care for all 50,000 patients, and our 80 physicians take turns covering that. But I would say, in many of the practices are smaller, and so they may not have that kind of same organized method for their patients. Or some practices are bigger, and in fact they don't pool because they're so big. It makes it cumbersome to pool the after hours care, and so the physician, and they don't necessarily all share the same record, in which case then the doctors just look after their own patients after hours and meet sort of the minimum requirements. So I could go into that in more detail, but there is some accountability, but how well it's working is varied. And of course, many patients, I would say, in Ontario and elsewhere in Canada rely on walk-in clinics. Of course, it's a little different in rural areas where they often are going to the emergency department that is staffed by their family doctor, but in suburban and urban areas, they're often relying on walk-in clinics. So contrast that with other countries. I've been really impressed to learn about, for example, in the Netherlands and in many other European countries, there is actually regionally organized after-hours care. And this is like organized to the point that every patient, every person living in the Netherlands, or in Norway, knows that there's like this one number that you call. And when you call that number after hours, you get in touch with a nurse, and that nurse would then tell you what to do. Perhaps it's you see your own doctor the next day. Perhaps it's you come and you see another a doctor in a clinic. Or in the case of the Netherlands, they actually even do home visits, and they have a supported system so that the doctor has like a driver, and the driver takes the doctor to the home visit, and they help the doctor to chart and maintain those records. And what's great is that they're looking after, a population together, this after hours care kind of regionally at around 100,000 to maybe even 500,000 patients together. And so as you can imagine, what that means is doctors then can pool their resources. So the doctors don't have to, it's a lot of strain on doctors to work a lot of evenings. But if you're only working, one evening in 20, because you're sharing the after hours responsibilities with others, it actually takes away strain from your own workday or work week. So when they shifted to this regional model, GPs liked it because it meant less working hours for them, more support for them. And of course, it's really wonderfully organized for the patients in terms of knowing when to get care and where to get care. Interestingly, in many of these other countries, they don't have some of their health human resources, their family doctors working in walk-in clinics because the walk-in clinics are just not there. You don't need a walk-in clinic if your family doctor and if everyone has a family doctor NP and they can get in a timely way. You don't need a walk-in clinic if you have organized after-hours care. So two more pieces I want to contrast here. So one is just how doctors are paid and organized. So in Ontario now, I would say about 55% or so of family doctors are paid by, so family doctors providing comprehensive longitudinal care, about 55% of them are paid by fee-for-service, with the remaining being paid by what we call capitation. So that's pay by the visit. So you get a set fee per patient based on their age and sex. And most doctors also have some kind of incentives. In the past, these have been, for example, for preventive care, to meeting preventive care targets. Although I would say the evidence and research that we've put out has found that those preventive care incentives haven't done much for really improving population-wide screening in the way that the incentives might have been thought they as would have been the intention with these incentives. Most family doctors are operating their own small business. So they're either doing that themselves as a solo doctor, or they're working with a group of physicians and operating their own practice. And we can talk more about the payments. I think we did when Dr. Maga was here during the last session. But all this to say that in some of these other countries, I would say more of the family doctors seem to be paid by capitation. And in some, like in Finland, they're actually salaried employees where they get kind of vacation and other types of benefits. There are some financial incentives for quality in some of these countries as well. So if you get to a certain quality target, you get some more money. In some of the countries, physicians do own and operate their own practice, like in the Netherlands or Norway. But as we're going to talk about, there does often come with more accountability. In other countries, they are employed by the health center, like in Finland. So they don't own and operate their own practice as much. So this is all related also to the concept of accountability. Because I will say that in Ontario, family doctors, in my opinion, have very little accountability. Really, the only thing that's in our contract in Ontario at this time really relates to after-hours requirements. Family health teams do have some accountability related to quality, but interestingly, it's the family health team, which is a superimposed structure that looks that really governs the other health professionals. And the doctor group is kind of a bit separate in that governance model. And in some ways, like, although they should really be working collaboratively, the accountability is with the family health team governance, not the doctor governance. And really, of course, as many of you know, as a doctor, you can just choose to practice anywhere in the province once you have your license, and you can choose to pretty much do anything that you want. So you can choose to, focus your practice on psychotherapy or fertility medicine, or if you wanted to, you could focus your practice on, a dermatology. So you could focus your practice in the way that you wanted, or you can open up your own comprehensive family practice. You can choose the hours that you work. There's really very little accountability and direction. You're your own small business owner. And contrast that with some of these other countries where there's more accountability, it seemed to me, as an outsider, on quality of care, including particular same-day access. So in the UK and Finland in particular, there are some there's quite a bit of accountability for enabling same-day access. And when we've talked to people there, though, there is a trade-off there with continuity, and the continuity is lower as a result of that. But there's also accountability of where they can practice and the kind of scope. So I think when we asked, for example, colleagues in the Netherlands, so, could a doctor, do you guys have doctors who specialize in sports medicine? And they were just, they were like, no, which insurance company would authorize a doctor to set up a practice that only does sports medicine? That wouldn't make sense. So I think they have these accountability mechanisms almost built in through the insurer authorizing whether someone can set up a practice. And very few of their family doctors in these settings work in specialized care. Now, of course, we do also have to keep in mind what I talked about, that there are more total numbers of doctors. And so part of the problem here in Ontario and in Canada is that we're relying on family doctors to fill needs in other parts of the system, including, for example, like emergency departments. So here are some graphs from some of the Commonwealth surveys that I mentioned. So this is from the Primary Care Physician Survey. And what you can see here is that when you look at you can look at each province, but if you focus in on the Ontario data, you can see that about 90% of Ontario family physicians work in an independent practice. So that's a private solo practice or physician group practice. And so about 68% are in a group practice, with about 17% still in a solo practice. That means that's a doctor working alone. So why is this important? I wanted to highlight this because there do seem to be some important differences. When you work in a group practice, it seems you're more likely to offer appointments on the weekend. You're more likely to use other personnel to manage chronic conditions. You're more likely to use electronic medical records and to have online booking or to review patient data. So it does seem that group practices are more able to do these kinds of things that generally most of us would consider to be more leading edge practices, desirable practice attributes. So how do we, this is some data that really looks at after hours arrangements. And they asked family doctors, do you have an arrangement internally or with another practice where patients can be seen by a doctor or nurse when the practice is closed, for example, after hours? And you can see in Ontario, 64% of the surveyed physicians said yes. That's higher actually than by quite a bit from most of the other provinces, and much higher than the Canadian average of 49%. So Ontario is actually in many of these regards doing better than some of the other provinces. But you can see that there's a lot more room for improvement if we compare to the Commonwealth Fund average, which was 75% of doctors saying they have these after hours arrangements. And then this slide really is about timely access to care. And, the first question is whether they're able to get a same day or next day appointment. And this is actually from the general population survey. So this is the patients responding, whether they're able to get a same day or next day appointment. And in Ontario, that's about 45%, which is again better than the Canadian average of 41%, but a lot worse than the Commonwealth average of 57%. And then we can again see that after hours here in Ontario, 42% that they can very easy or somewhat easy to get after hours medical care, better than the Canadian average, but worse than the Commonwealth Fund average. And then there's another question related to kind of phone call answers. So the last part that I wanted to contrast between Ontario and these other 9 comparator countries, or particularly Finland, Netherlands, UK, and Norway, was around information technology. So in Ontario, very few practices use online booking or secure messaging. I would say we have fairly siloed information systems. So even the vaccine information system at Covaxon for COVID vaccine, documentation in the province doesn't integrate well with the electronic medical record. So if we gave a COVID vaccine in our practice, it actually wouldn't register in the provincial system. We would have to double enter. We would have to double enter and put it in the provincial system, log into that system, and then also enter it into our system, our electronic medical record system. The hospital records and the family doctor records don't interact very well. There's been some progress towards that, where now, I might get an e-notification if someone is discharged, and I might get that automatically into my electronic medical record, but that's only for certain hospitals, and it generally doesn't happen as much with specialist consult notes. So we have very siloed information systems. If somebody's in getting home care, for example, like I can't see those records. I don't really know. I can maybe see some of them if I log into a separate system, but certainly they don't come back to my own record where I'm managing the patient. And I will say that, we've had electronic medical records in Canada for some time now, and in Ontario. But I'll show you some data in a minute to just say, I think we're not using it to the degree that we should be when it comes to using it to identify, for example, someone who is overdue for their pap test or their blood pressure, or, their thyroid lab test. we're often not using it in that kind of planned, proactive way in which we could be, and instead often using it more almost like a word processing machine, where we're writing our notes in it, and the notes are organized and easy to read, which is definitely wonderful. And we can, more easily make referrals because we can auto populate things, etc. But we're not using it in the way that we could be, and the way that some other countries are. So when we look to other countries, it was interesting to hear in particular, for example, in the Netherlands, how there's like lots of use of online booking and secure messaging. So by secure messaging, I mean that's like a different than email because it's secure, but you're basically doing messaging directly with the doctor. Usually that messaging is asynchronous. So that means like the doctor can send it to you and you can respond at whatever time you want to respond, and vice versa. There's definitely lots of use of the electronic systems to manage care proactively, more so I'd say in the UK, tied to their quality of care, quality incentives, and in the Netherlands. And, in some of these countries, patients and other healthcare providers can better access the entire patient record. So patients can easily access their patient record through an online portal in Finland, and this includes all of the different aspects of the healthcare system. And then they can have their, other healthcare providers see that whole record as well with permission. So this is just some of the data that really, I think, speaks to what we've just talked about from the Commonwealth surveys. So, the bottom line here is that fewer Canadian primary care physicians offer access to patients electronically compared with the Commonwealth Fund average. So when we look at the proportion communicating with their practice via email or a secure website, in Canada, it's just 23%, and you can see all other Commonwealth countries, it's much higher. And when it comes to requesting appointments online, in Canada, it's 22%, and all other countries, it's much higher. I will say that I myself am now using online booking for the last year, and I really love it, and I think my patients love it too, and it would be terrific, I think, for more doctors and patients to have access to that. This really talks about what we were saying about how can you leverage other types of personnel to care for people with chronic conditions. So team members, so fewer Canadian primary care physicians use other personnel or team members like nurses or case managers to care for patients with chronic conditions compared to the Commonwealth Fund average. And again, here you can see Canada down at 62%, the Commonwealth Fund average is 77%, but you see, the Netherlands and the UK up there at 95, 96%. And then you can see Ontario is kind of, it seems actually lower than some of the other provinces when it comes to this team-based chronic condition care. So now most doctors in Ontario, family doctors, do use electronic medical records. So you can see 89% of those in Ontario do use electronic medical records. And so this is really nice and get, close to the Commonwealth average of 93%, and it's increased over time. However, how we're using it is not necessarily optimal. So can we actually, when it comes to other kinds of information, in Ontario, we actually don't have the data on whether patients can view test results online, but only 6% of family doctors say that their patients can view their patient summaries online, or that they could request prescription renewals online. And this is much lower than the Commonwealth Fund average. And similarly, this kind of really highlights the siloed electronic systems that we have. So where, it really shows whether family doctors can electronically exchange information with doctors outside their practice. And in general, when it comes to patient summaries or lab and diagnostic tests, it's, 30% or 35% in Ontario compared to 63 or 65% in the Commonwealth Fund average. So I presented a lot of data from the Commonwealth, but one of the important things I wanted to highlight that's a bit of a pet peeve of mine is that the Commonwealth Fund actually does not have a question related to relationship continuity in primary care. And that is actually an area where Canada generally does really well, and we would outperform countries like the UK or Finland. because most people in Canada see the same family doctor or NP for their primary care most of the time. And in fact, there's tons of evidence out there about the benefits of relational continuity. So I'm showing you on the right-hand side here a wonderful kind of schematic put forward by by a group in Alberta that just shows that, basically if you have higher relational continuity, so you're seeing the same provider over and over again, you're more likely to get recommended preventive care, less likely to use the emergency department. You're more likely to have other health outcomes and better care quality, more likely to have cost savings. You're actually even less likely to die. So some really interesting data on relational continuity, an area where we're doing well. So lots of information I presented to you. I see there's like 86 comments in the chat, so hopefully somebody can summarize those for me. But in summary, we spend less on primary care than other comparator countries. Although we have similar numbers of family doctors or GPs, we have fewer doctors total, and more of our family doctors are doing specialized work and working in walk-in clinics. And some of the things that we can learn about these comparator countries are just, how they organize care geographically. They generally have more physician accountability, more use of interprofessional teams, shared after-hours responsibility, which obviates the need for walk-in clinics, and better use of information technologies. Of course, there can be some trade-offs in all of this. So in some countries, for example, with guaranteed access to a clinic, there is lower relationship continuity, which is, I know, an important value that you guys have already started to articulate. So look forward to your questions.